Acute respiratory distress syndrome. In this presentation, our objectives will be the student will understand the physiological process of acute respiratory distress syndrome, understand contributing factors that may cause ARDS to occur, understand how ARDS is diagnosed, understand how to recognize signs and symptoms and prevention of ARDS, understand the treatment and treatment goals of ARDS, understand ventilation and PEEP and when to implement these treatments, and finally understand complications which can arise from ventilation. Acute respiratory distress syndrome is a life-threatening acute inflammatory lung injury. ARDS was first described in 1967 by Dr. David Osbaugh as a syndrome of severe respiratory failure and widespread infiltration seen on a pulmonary radiograph, reduced compliance, and hypoxemia unresponsive to oxygen treatment. There are about 200,000 cases of ARDS each year in the United States, and even the best medical care, or with best medical care, 30 to 50% diagnosed with ARDS die of it. ARDS is a severe lung condition that progresses rapidly and results from an acute injury or illness to the lungs. Okay, so ARDS causes a systemic inflammatory response and occurs when tiny air sacs in the lungs, known as alveoli, begin to fill with fluid. As fluid continues to accumulate, it causes the lungs to become stiff and harder to inflate. This makes it more difficult to breathe and leads to low oxygen to the blood or hypoxemia. ARDS is believed to go through 3 phases: the executive phase, proliferative, and fibrotic. In the executive phase, damage to the alveolar endothelium and vascular endothelium causes inflammation and produces leakage of water, protein, and red blood cells into the interstitium and alveolar lumen. The proliferative phase occurs approximately 7 to 14 days after the injury has occurred and incorporates repair of the damaged alveoli structure. Lastly, the fibrotic phase includes chronic inflammation and fibrosis of the alveoli. It is important to note that each phase and overall disease process is variable. Most people who get ARDS are usually already in the hospital for trauma or illness. The causes of ARDS are divided into 2 categories, which are direct or indirect injury to the lungs. Direct injury to the lungs include aspiration, pneumonia, chemical inhalation, near drowning, or trauma, whereas the indirect causes include sepsis, severe pulmonary infections, blood transfusions, reactions to medications, and burns. ARDS can develop over hours to several days in patients who are initially stable and suddenly develop respiratory distress. It is essential to recognize key factors in patients at risk for developing this condition. Signs and symptoms include increased work of breathing, hyperpnea, tachypnea, noisy respiration, cyanosis, pallor, and intercostal substernal retractions. Abnormal lung sounds are not heard on auscultation. A classic sign includes refractory hypoxemia, decreased lung compliance. The chest x-ray may show diffuse haziness or whited out appearance of the lung. Diagnostic assessment includes by establishing a lowered partial pressure of arterial oxygen value determined by the ABG measurements. Sputum cultures may also be ran. Hemodynamic monitoring. The pulmonary artery capillary wedge may be low to normal. Prevention. Since ARDS occurs after first healthcare contact, it is considered as a complication of critical illnesses. Avoidable exposures include aspiration, IV fluids, blood transfusions, delayed treatment of sepsis and pneumonia. Primary prevention includes vaccination and restrictive transfusion practices.
Treatment of ARDS. There is no direct cure for acute respiratory distress syndrome, and treatment is mainly directed at preventing the progression of the disease. Goals of treatment include support of the patient while allowing the lung to heal, keeping enough oxygen in the blood to prevent further damage, and preventing other complications related to hospitalization. Ventilation and positive end expiratory pressure are often needed for the patient suffering from acute respiratory distress syndrome. Positive end expiratory pressure is utilized to keep oxygen saturation adequate by keeping the lung inflated and preventing the alveoli from collapsing upon exhalation. Positive end expiratory pressure is normally set at 5 centimeters of H2O, but may be increased if the alveoli have collapsed. Additionally, levels below 5 may be used to avoid hyperinflation in acute asthmatic and chronic obstructive pulmonary disorder patients. Specific medications are used to facilitate ventilation in ARDS patients. Sedatives are given first to patients to sedate and prevent them from fighting the ventilator. Neuromuscular blockers are given second to minimize restlessness, decrease anxiety, and facilitate ventilation. Ventilation is necessary when the patient presents with the following signs: respiratory rate below 10 breaths per minute or above 28 breaths per minute, labored breathing, metabolic acidosis, a PaCO2 above 55, a PaO2 below 50 on room air or 60 on oxygen support, a pH less than 7.25, and a Glasgow Coma Scale score of 8 or less. Ventilation can lead to a number of infections, such as ventilator-acquired pneumonia, and for this reason is not to be utilized for longer than 1 to 2 weeks. If the patient still requires extensive oxygen support, a tracheostomy will be considered. Due to the high bacteria concentration inside the mouth, ventilator-acquired pneumonia is a commonly acquired illness by ventilated patients. Steps for prevention of ventilator-acquired pneumonia should be followed from the beginning of the patient's ventilation. These steps include proper hand hygiene, oral care every 2 to 4 hours, keeping the head of the bed elevated to at least 30 degrees, a daily sedation vacation, a daily assessment of readiness for extubation, peptic ulcer prophylaxis, deep vein thrombosis prophylaxis, and performance of passive range of motion exercises. Patient education. The survival rate is low for patients diagnosed with ARDS. Education on risk factors is the best way to prevent this syndrome from occurring. Modifiable risk factors for ARDS include current or past smoking, alcohol abuse, and obesity. Additionally, patients suffering from acute respiratory distress syndrome are at risk for developing acute respiratory failure. Healthcare providers should focus on the prevention of this progression. Monitoring neurological status, respiratory status, and arterial blood gases is of extreme importance for these patients.
Okay, NCLEX question number 1. You're discussing the topic of acute respiratory distress syndrome to a group of new nurses. At the beginning of the lecture, you assess the new nurse's understanding about this condition. Which statement by a new nurse demonstrates he understands the condition? The options are A, the condition develops because the exocrine glands start to work incorrectly, leading to thick, copious mucus to collect in the alveoli sacs. B, ARDS is a pulmonary disease that gradually causes chronic obstruction of airflow from the lungs. C, acute respiratory distress syndrome occurs due to the collapsing of a lung because air has accumulated in the pleural space. Or D, this condition develops because alveolar capillary membrane permeability has changed, leading to fluid collecting in the air sacs. The answer is D. The condition develops because alveolar capillary membrane permeability has changed, leading to fluid collecting in the alveoli sacs.
NCLEX question number 2. The nurse is assessing a client with multiple trauma who is at risk for developing ARDS. The nurse should assess for which earliest sign of ARDS. A, bilateral wheezing. B, inspiratory crackles. C, intercostal retractions. Or D, increased respiratory rate. The answer is D. The earliest sign of ARDS is increased respiratory rate, which can begin 1 to 96 hours after initial insult to the body. This is followed by increasing dyspnea, air hunger, retraction of accessory muscles, and cyanosis. Breath sounds may be clear or consist of fine inspiratory crackles or diffuse coarse crackles.
NCLEX question number 3. Which statement by the nurse when explaining the purpose of positive end expiratory pressure to the family members of a patient with ARDS is correct? A, people prevent fibrosis of the lung from occurring. B, people push more air into the lungs during inhalation. C, people allows the ventilator to deliver 100% oxygen to the lungs. Or D, PEEP prevents the lung air sacs from collapsing during exhalation. The answer is D. By preventing alveolar collapse during expiration, PEEP improves gas exchange and oxygenation. PEEP will not prevent the fibrotic changes that occur with ARDS, push more air into the lungs, or change the fraction of inspired oxygen delivered to the patient.
Discontentation. This concludes our presentation. Thank you for watching.